Okay, I think we can start now. Can we start, Giuliano? You know, Victor?
Yes.
Yes, okay. Well, good evening to all colleagues and friends. My name is Mario Cavagna, and I am the coordinator of the Oncofertility Committee of the Brazilian Society of Human Reproduction. This evening, we have the pleasure to receive Professor Kutluk Oktay in this meeting. Dr. Oktay is professor of gynecology and obstetrics at Yale School of Medicine and is the director of the Innovation Institute for Fertility Preservation and IVF in New York. Everybody knows Professor Oktay. He's one of the most important scientists and researchers in the field of fertility preservation. We also have the pleasure to be with Dr. Juliano Bedowski, who is PhD in medicine at the School of Medicine of Ribeirão Preto of the University of São Paulo, and research fellow in the Institute of Fertility Preservation of Dr. Oktay. Juliano is one of the most promising young reproductive physicians in Brazil. And regarding this point, Dr. Oktay, I declare you guilty.
Happy to be guilty.
And
I admit, I profess.
Okay,
I confess.
And tonight we have the pleasure to listen the lecture of Dr. Oktay. He will present us the lecture entitled Ovarian Cryopreservation and Transplantation for Fertility Preservation, 20 Years of Progress. I think you can start now, Professor. Thank you very much.
Thank you. Thank you for the kind introduction. As some of you know, I love visiting Brazil, and I have worked with many Brazilian fellows and colleagues. So it's a pleasure for me to be with you, even though virtually. I think Brazil is one of those places. It's the least fun virtually, right? It's such a wonderful country. And I know that now you guys can't travel here either, right? There's a recent ban, and hopefully we'll get through this. In the meantime, today I want to share with you my 20 plus years of experience with ovarian cryopreservation and transplantation and the progress that we had from the very beginning till the last second, literally a couple of days ago. So there will be an update. All right. So can we go ahead? We're set up on YouTube? Okay. Good.
Yes.
Okay.
Okay. Hopefully this will cooperate. First of all, I have no conflict of interest other than I'm guilty of contributing to Giuliano Bedowski's development. Some of the work that I'm going to present here has been supported at various grants from National Institutes of Health, and I'm funded by them. And what I'm going to show here is maybe a quarter of the work we do. Well, my laboratory also focuses on molecular aspects of how chemotherapy affects ovarian reserve, as well as how aging affects it. So we have a lot of ovarian biology work, some of which Juliana was involved. But we will focus on the part of the clinical research that I've been doing, and here's some funders. Now, fertility preservation is a strategy, and there is no one-size-fits-all approach. It all depends on the circumstances, and this slide summarizes our 20-plus experience and the resulting strategy here. We're not going to talk about male But in situations where you're dealing with adult or post-pubertal person, obviously it's straightforward. Pre-pubertal boys, we are doing testicular cryopreservation experimental and currently no successful transplants, but this is something to watch in the future. But today we're focusing on the female side. So if a patient comes in and is about to receive a form of medical treatment that can affect ovarian function, we look at several things. If this patient does not have ovarian involvement with the primary disease, then if only receiving radiation treatment, ovarian transposition may help, but not all the time. About 50% of the time this would succeed. And because of ovarian vascular kinking, scatter radiation, it may, and sometimes ovaries will migrate, this may not work. So when we do transposition, we always consider an additional method of those below. If, again, no ovarian involvement, then the next question we ask is whether we can delay chemotherapy. Because if we can delay chemotherapy, there are procedures where we have, or generally most people have more experience with, that includes embryo or oocyte cryopreservation. But if that person has an estrogen-sensitive cancer, standard ovarian stimulation protocols may not be appropriate. In that case, we have developed ovarian stimulation protocols. We've done these initial trials, and over the past 10, 15 years, we have decided that letrozole is potentially a better approach to enable these women to go through stimulation without significant estrogen exposure. And we have studies going back 10, 15 years showing that recurrence risks are not increased with letrozole. When there is not sufficient time, one of the approaches that we have also developed is random start. Many of you may not know that, but we were the first to describe and give this name to the protocol, random start, with one of my fellows, Dr. Sermezar, because in most cases, there are enteral follicles that allow you to start stimulation anytime during the cycle. However, when the time is really short, or you're dealing with a sexually immature individual, or children, prepubertal, then ovarian cryopreservation comes handy, and which is the topic of the talk today. And there is also in vitro maturation, which can be used with both strategies that I will talk about. And sometimes we combine these approaches as well. I have patients who've done both as well. So, however, today's focus is on ovarian transplant. It would take me 5 hours, probably, maybe a whole day, to go through all these things in detail. So I want to give you today's first historical perspective. It is important because that will show you how perseverance in research will pay off in terms of advancing the field. I will tell you the current state from the very first transplant we did to the procedures we've done a couple of days ago, and what limitations we are facing and what efforts we are putting out there to improve success. In the end, I will share with you with videos what kind of technical surgical progress we had in 21 years, because the first ovarian transplant we've done, and it was the first ever with cryopreserved tissue, was more than 21 years ago now. If you have a little extra time, I'm going to touch upon oocyte freezing from ovarian tissue and elective ovarian tissue freezing as well, which is another area that is slowly emerging. So this figure is from our recent paper that was published in Reproductive Sciences recently. Here you go. You can see the guilty person, your shining star, Dr. Bedosky, and with another fellow from Italy, Dr. Loris Marin. We put out this review, which summarizes the whole entire progress, starting with studies in animals, then the first laboratory studies we've done, and the first transplant we did in 1999, but published in 2000, to earlier pregnancies, and finally development of robotic, as well as the heterotopic transplants, first embryo from ovarian transplant. These are all largely accomplishments of our group, and I'm going to go over this. Now, ovarian transplant itself would not be such a groundbreaking procedure if you were just dealing with fresh tissues. We all know that ovarian tissue is pretty malleable. You know, you can do all these cystectomies and everything. Sometimes these ovarian pieces broken up, you know, you patch it back on the ovary, things work pretty well. But what makes this procedure unique is the ability to freeze these tissues and then later on revive them and then restore fertility. And that all is thanks to earlier medical laboratory research in developing cryoprotectants, going back to 1990s and earlier with the development of effective cryoprotectants. Then the studies in rodents and sheep showing that cryopreserved ovarian tissue can result in ovarian function and fertility. And then laboratory work, again, in Gosden laboratory with human ovarian tissue. So at the end of my subspecialty training in infertility, I went to work with, as a part of Royal College of OBGYN, American College of OBGYN exchange fellowship, to work with this scientist, Roger Gosden, who was a pioneer in the animal studies, in his lab in between 95 and 96. There where we did the earlier work on this, looking at the viability of follicles from cryopreserved human ovarian tissue. And we show that follicles from human cryopreserved tissue were viable. We're talking about 1997. And then also developed a immunodeficient mouse model where you could graft human tissue into immunodeficient mice. And we've shown that follicles nicely graft and grow in that model, indicating that transplant should work in humans. And we even had probably the first review on the topic, and cryopreservation of immature human oocytes and ovarian tissue and immersion technology back down in 1998. So these were the beginnings of the procedure. So once I came back to the United States, I brought this technique of ovarian tissue harvesting from Gosden's lab, where you would isolate ovarian cortical pieces from the stroma. You don't need the whole ovary for this. Most primordial follicles are within 100 microns of the surface epithelium. And this cortex would be separated from the stroma so that the cortical pieces will be prepared. And then they will be put into cryo vials, and then they will be frozen with a slow freezing protocol, the outline here. Since then, we have, in the last 20 years, we have improved on this in various aspects. So I came back to the States. I quietly started a research protocol. We found the first patient who had actually already had her ovarian tissue frozen elsewhere. She wasn't a cancer patient. It was an endometriosis, only ovary that was removed. And she wanted to do this more for hormonal reasons at that time, didn't want to have a baby. But as a first case, we agreed to do this. You know, I quietly did this, and our local hospital news put something out there, first human ovarian tissue transplant, New York Methodist Hospital, which is part of Cornell network at the time. So we're talking about February 1999. It also went to the larger network, network news in April. They talked about that we've done the transplant. Again, quietly, it was in the hospital news, and we were getting ready to present this at ASRM in October. But Roger Gosden, my mentor, unfortunately couldn't resist in talking to the press at that time. So this thing exploded to the entire world at that time, and pretty much was on the cover of every major newspaper. And it was hailed as a menopause reversal at the time, of course. I mean, people would be, we're looking at September 1999. This was just before the ASRM meeting in Canada. And people were speculating that we would be creating babies for women in their late 60s, and we would reduce aging, etc. Obviously, initially, this procedure was designed for fertility preservation. So that kind of jump-started the field. Obviously, we did publish this in New England Journal of Medicine at that time as a short paper, June 22nd, 2000, with my fellow at the time who helped with the thawing and preparation of the tissue. And this resulted in hormonal production and ovulation and about 9 months of function or so, with somewhat originally compromised tissue from prior procedures. So this established the proof of principle that cryopreserved ovarian tissue can result in function and result in ovulations, and jump-started the whole progress. And that was an orthotopic transplant in 1999, laparoscopically done. I'm going to show you the video at the end of the talk for a comparison with the most recent techniques. But we also went ahead and developed the first heterotopic transplant techniques where the tissue goes outside the pelvis. And these were initially in the forearm, resulting in follicle growth. What you see here is patient's forearm skin and muscles. And then later on, we moved this to the abdominal skin area. And I've developed a patented needle for this to aspirate follicles from there. We generated embryos. So originally we found, why did we want to do heterotopic transplants? There are some advantages. They're less invasive. You can do it under local anesthesia. You can actually inject agents or ovarian stimulants directly into the grafts. If there's a risk of recurrence of cancer, it's easy to monitor and remove this. Multiple transplants are more feasible. Maybe we'll talk later when we're talking about hormonal restoration. This might be more feasible this way. The patients we've done this had pelvic radiation or cervical cancer, etc., that you couldn't really use the pelvis. And the other thing is, if a patient gets pregnant, obviously, if you get this egg from the transplant directly, there's no ovary functioning in there, we could be sure that the pregnancy came from the transplant. But as I'll show you, we're not so sure about that anymore. And as I said, if you were to use this for hormone replacement, this might be a more practical approach. What are the cons? We're finding out that it may not be a optimal environment for oogenesis. Looks like follicle dynamics are altered. Perhaps you're going to need IVF, perhaps not. I'll show you something. The cosmetic issues, originally a forearm site was a little bit of an issue, especially when patients were ovulating. They were telling me that the follicles would get pointy and visible in the forearm. That's why we moved to the abdominal area. So we still don't know the exact ideal location, but I think we have some ideas now. So as I told you, with heterotopic transplants, follicle dynamics are changed. This is from the first report on this case in Lancet 2004. Now, the stimulation length is similar to average cycle, 10.8 days. But what we found was that if you aspirate on average an 8.7 millimeter follicle, you get a GV, but 11.5 millimeter, you get a mature follicle. So follicles in heterotopic sites grow to much smaller sizes. That doesn't surprise me because in SCID mice, immunodeficient mice, human follicles will grow up to 5 millimeters. So space, we don't exactly know why, but to this day, when I do a trigger on heterotopic transplants, you got to do this around here. As a matter of fact, this is one of the eggs I got last week, and this egg turned into a blastocyst, and we just cryopreserved it, waiting for PGT results, and a heterotopic transplant patient. And this came from a 10.5 millimeter follicle. However, in the earlier transplants, we found that, for example, we had in 10 retrievals, we had 22 oocytes, 9 were suitable for IVF. We had 2 abnormal embryos. At that time, we were doing fish. And then we had 1 grade 1 to 2 4-cell embryos. So 4.5% yield in terms of normal embryos at that time. So I'll show you, we have some improvements on that, but this has been a challenge with heterotopic transplants. I told you that in heterotopic transplants, we would not expect pregnancies without IVF, but something strange happened. This is a Hodgkin lymphoma survivor who had bone marrow transplant, was way in menopause, and I did the transplant here subcutaneously. And while we were getting ready to do retrievals, she started getting pregnant on her own. She had this baby first, right after that this and this one. She had one miscarriage first, so she had like 4 back-to-back pregnancies, and in the end, she had to have a tubal ligation done. So if anyone of you want to hear her story, we did a radio story called Radiolab. This is a public radio show, and you can actually go to Radiolab and listen to her. It's really an interesting story. We had some speculations on now in bone marrow transplant patients sometimes do get pregnant. They may still have some few follicles remaining in there, but this patient got pregnant 4 times back to back. We had some ideas that perhaps the transplanted ovary is helping the other ovary to heal, including germ cell transfer or renewal, etc. We published this theories in 2011. Who knows? But interesting things happen when you transplant ovaries, even in subcutaneous areas. Of course, that creates complications with children who are born from these transplants when you're trying to explain how do they came to life. This cartoon, I think, well represents that. Other colleagues from Australia have actually achieved to have live births from heterotopic transplants by transplanting them inside the abdomen underneath the peritoneum. You see follicle development underneath the abdominal wall, beneath the pelvis. Here is the follicle, large follicle here. And actually, this patient had twins. The reason for that is the patient's harvesting was done for a granulosa cell tumor. They didn't want to put it in pelvis. They removed the graft after during the C-section. There was actually some recurrence in there, but the patient was safe. So we do know that you can have babies from heterotopic transplants, and perhaps that intra-abdominal site, subcutaneous, subperitoneal, probably is the best approach. So as I said, we started in 1999, but the years passed on and pregnancies started coming, and we had no idea what the success rates were. So here comes another Brazilian fellow of mine, Dr. Fernando Pacheco, was working with me at the time. We said, why don't we do a meta-analysis to figure out the success rates? And we put together at the time all the reports for pregnancy attempts with transplants. Here are cases and various people who reported. And we found that on average, women who are doing ovarian cryopreservation around the world was 29 years old. This is the range, but I have patients as young as 1. You can do this at any age. And they were on average coming back 4 years later. Our patients are coming much later. I'll show it to you. Pretty much normal pregnancy. So cumulative clinical pregnancy rate is almost 60%, and cumulative live birth is close to 40%. 2/3 are having babies on their own without any help, and 2/3 have prolonged hormonal function, menopausal reversal, at least having 6 months or longer function. But you're going to see that the limitation is that on average, these grafts lasted a couple of years, and there's a great variability in that. So that's the limitation of ovarian transplants. One reason for that, when we do transplants, we're doing them like skin grafting. So you have to graft these pieces onto vascular surface and allow the vascularization to happen spontaneously. And that takes about 10 days. During that process, you're losing about 2/3 of the follicles. As a matter of fact, the losses with freezing and thawing are perhaps only about 5 to 10%, but the most losses are occurring during that process. And that limits the longevity of transplants. So we set out to then improve these aspects of ovarian transplants. One of the areas is that even though that has a minor role, the freezing and thawing part in follicle survival, we've been also working on vitrification with colleagues at San Mariano University. Dr. Yodo Sugishida again came to my lab, spent 2 years and testing this device he developed with Dr. Nao Suzuki and Kitazato. 2 devices. One is an open device. One is a closed vitrification device specifically designed for ovarian tissue vitrification. The problem with vitrification with ovarian tissue is you're dealing with tissues, so penetration could be limited, and the tissue temperature change could be uneven. But with these devices, certain aspects were improved. So we compared these devices to slow freezing. And what we found was that that by looking at follicle density, DNA damage, apoptosis, you're seeing that fresh versus vitrification or slow freezing. Of course, there is more damage with these. But these two approaches, at least histologically, looked pretty similar, actually, with vitrification that seemed to be a little bit less apoptotic follicles, but overall, when you compare the non-apoptotic follicle density, seem to be similar. So at least at histological level, they seem to be yielding similar results, but that doesn't mean that they will give similar function. So nearly all pregnancies are from slow freezing. Right now, this is the approach we stick with. Sometimes we may do half and half, but this is one area of progress. This second area, as I said, is vascularization issue. So we set out to improve that. Sphingosine 1-phosphate is a ceramide-induced death pathway inhibitor. And we and others have shown that it actually blocks chemotherapy-induced follicle death. But there is also some evidence that it may affect vascularization. So we tested this agent in ovarian xenograft models to see if it can improve graft vascularization. Because if it did, this agent has a synthetic analog, which is clinically approved for multiple sclerosis treatment. We might be able to use this in future trials. So what we did was to graft human tissue into these skid mice and infuse this agent through a pump for 10 days, and then remove the grafts on day 1, 2, 3, 4, and 10, as well as those from controls. And then looked at various markers, vascular density, we assessed the stroma, follicle survival, apoptosis, hypoxia. I will show you just one graph from that on vascular density first. Here, the control is showed in light bars and S1P treated in dark bars. By day 2, you're already seeing that with S1P infusion, you have much larger mean blood vessel density. By day 3, you already have enough that you would get without it by day 10. So by day 10, you have double the vascular density when you use this. And in terms of follicle density, with S1P, you're almost preserving all the follicles that fresh grafts have, but with control, you have lost almost half of it. And you can look at it, the baseline, which is fresh tissue, nice. If you didn't use S1P, you can appreciate how the stroma is altered, very few follicles. And S1P actually not only preserves follicles, but also stroma is in much better shape. So, however, this agent is only for research use. You can't use it in humans. Has a very short half-life, so you would have to infuse it continuously. But as I said, there is this agent fingolimod now approved for multiple sclerosis, so we're considering future clinical trials for this agent. But nevertheless, we still don't have this for use. Other options to improve that we looked at is using extracellular matrix scaffolds, which can enhance vascularization. Alloderm is one of those scaffolds, and it's regenerated from cadaver skin. All the cells are removed. And we've shown in xenografting studies that it integrates with human tissue. This is the extracellular matrix, and this is the human tissue. You can't tell which one is which. And it's not toxic to oocytes, and look like works well with vascularization. So we incorporated this alloderm into our surgical technique together with another area of improvement using robotic surgery. Currently, we're using Da Vinci Xi. Why do we use robotic surgery? You have improved precision, 3D vision. You have articulation better than human wrist. You have no tremor. You can have all the cappuccino you want, and you're not going to have tremor. So we can handle tissues more carefully. We can do fine suturing. I'm sitting down, and I could be sleepless all night, but still sit down and rest, and I do the surgery. And I like the other one feature of this robotic surgery has virtual reality training, and we can use those programs to prepare for various techniques of transplant. And it also, I think, reduces time from Petri dish to the graft, because once we start thawing, I want to get this in and graft this. So anything that reduces that time from thawing to the patient benefits us. So that's why we've been using robotic surgery. And as you can see, I'm operating here in the console here, and there's on the monitor, my assistants are introducing all the instruments, etc. When we do this, typically we will use all 4 ports, camera and 3 arms, retract and do the suturing, and then we will have an access port to bring the graft in. We would set up in the OR. This is probably one of Giuliano's setups. So we can here see that tissue right from the bank. We will be thawing that. Alloderm is here. Alloderm is actually in a dried version, so we will be hydrating this. And then we would take the tissue through gradients of cryoprotectants, and then we will be reconstructing it on a cold stage on alloderm. Here is a graft that is being reconstructed with the pieces sutured on it under microscope, and that's what Giuliano does when we do these transplants. This is another fellow of mine, Dr. Talon, who also helped with that. And we're loading it up on Grasper, and this will be brought inside. Currently, most common approach is we are using the residual ovary. So before we do the transplant, we would measure that ovary, calculate the surface area we might get by bivalving the ovary. So we have an idea about what size of graft we can put in there. So we sort of plan on how we're going to suture pieces, how tight, etc. So just the initial video to show you the port placements and some, the thawing pieces. You can follow all these, right? I'm not. We're suturing them on alloderm. This is under operative microscope. And you see a reconstructed graft here. So typically ovarian transplants result in limited follicle growth. You would get 1 or 2 at a time. And what we found with these initial 2 patients was that this mouse is so sensitive. If you look up here, this patient had so many follicles and nice quality, multiple embryos, and same with the other patient. And they both ended up conceiving. This is a second look laparoscopy in 1 patient. You can't tell whether this was alloderm or whatnot. Everything looks completely natural and normal. So as I said, this resulted in live births in both patients, and we reported this in back in 2016, and Dr. Bedowski was involved in both of them, as I told you. Since then, we have done more of these cases. Why is this rolling like this? Here we go. Okay, so these are the first 2 patients that I showed you. You can see that we have patients coming back at decades or longer later. Her tissue was cryopreserved at age 23, then came back at 35, and this one 22, 29. 11 years later, this one 8 years later, 10 years later, 10 years later, 11 years later. So our patients take long. You'll see that majority of them are Hodgkin or non-Hodgkin, but we do have an ALL patient and other lymphovascular diseases and 1 endometrial carcinoma. This is heterotopic, again, because of the pelvic lymph node dissection and prior scarring. We did a heterotopic transplant. I will summarize how long it takes for the grafts to function, and but as you can see from here that every patient who we attempted who desired pregnancy, for example, the first reports, now they had their second babies as well. And we have one that's 32 weeks pregnant, the other one with ALL 20 weeks pregnant. And this patient, we have cryopreserved several embryos. Obviously, she doesn't have a uterus. We'll use a GC. This patient was recent, and so we are just going through ovarian stimulation with her. Again, she will use a gestational carrier, but this summarizes it. In our case, our mean ages are earlier, 22, and they're coming back on average 10 years later. And on average, you don't need to transplant more than 50% of the ovary, because we usually remove a whole ovary and cryopreserve that. It takes about 14, 15 weeks, close to 4 months to see function. Our grafts are already lasting longer than the average reported in the literature, 3 years or longer, and some of them are already still functioning. On average, we're getting about 15, 16 oocytes, 96% fertilization rates. If you leave the heterotopic transplant out, about on average 10 viable embryos. In those that we've tested, we did PGTA, about 50% euploid, but every one of them had greater than 1 year endocrine function. Every one of them we were able to generate embryos. And of those attempting, every one of them had live ongoing pregnancy. Again, smaller numbers, but all promising. So while I was preparing for this lecture, we also had an idea about comparing heterotopic to orthotopic now that we had extended experience. And another fellow of mine from Italy, Loris Marin, put this data together, and just want to show you the comparison here. In general, orthotopic patients are younger because of cancer types, I believe. But the age of transplantation is at least statistically similar. Percentage of ovary transplanted, time to function. So it tells you that it doesn't matter where you transplant, it still takes about the same time to see the function. And longevity so far seems to be similar too. But when you get to oocytes retrieved, fertilization numbers, number of embryos generated, and viable embryos, heterotopic transplants are doing a lot worse, largely due to the initial cases. But overall, heterotopic transplant is my second choice. If I can't absolutely do orthotopic, we do heterotopic, but there's still things we need to figure out. However, we have improvements in heterotopic transplant, as I told you. Monkey studies suggested that a mental flap might improve vascularization to abdominal heterotopic transplant. So this is a case where I'm going to show you this heterotopic transplant case later, but this transplant was in the abdomen. And we decided later to do an omental flap, attaching omentum there to enhance vascularization because embryo quality was not good. And actually, we did see improvements after that, as I will show you later. So follow-up, we had, as I said, babies from the first transplants. And one complication we had that I think these babies didn't like me. But it looks like the second babies might start liking me. So I'm hoping that that will be the case. And so I've gone through about a 21 plus years of progress with our research, and including earlier animal work, we're talking about 30 years of progress that brought us from animal studies, first cryoprotectants, the first report of our transplant, our first report of embryos, and to robotic techniques, a tremendous progress. So I want to show you visually what kind of surgical progress we had. Up top, you will see the very first transplant where we did laparoscopically, straight laparoscopic approach. This is one of the latest ones we did with robotic orthotopic, and this is robotic heterotopic. So I'm going to get them to start one by one. So you'll get to watch them side by side. Okay. You'll see the thawing of these pieces. On the left, you see the alloderm. So I'll start up top. In the very first transplant, we didn't have the alloderm idea, so we were using what's called Surgicel. It's just a cellulose membrane to keep things together. So up top from 1999, you'll see the reconstruction of pieces on that membrane. Now the top, this one, we're using an atrophic remaining ovary. When the ovary is not enough, we extend into the parametrium. You'll see that. Over here, this is the heterotopic technique. I'm marking the area with the needles from outside, so I know exactly where I'm putting it, because I will have to come back and do retrievals abdominally. On the left, the transplant is going in the residual ovary. On top, this patient didn't have any ovaries. It goes in the pelvic peritoneum. On the right, it's going under the abdominal peritoneum. The bottom two ones are grafts that are constructed with alloderm. The white membrane is alloderm. You're seeing that. We're suturing it on the left with laparoscopic suturing all around, anastomosing it to her remaining ovary. And at the end of the procedure, you can see that it pretty much looks like an ovary even at that point. You're seeing 20 years of progress surgically before your eyes, and you'll decide which technique. Another thing that I want to mention is that ovarian cryopreservation is actually can also be combined with oocyte freezing. We aspirate antral follicles from every case of ovarian freezing, and this way we can actually obtain, in some cases you can excise them. Again, we have some data together with our colleagues at San Mariana University. You can also aspirate them during laparoscopy while harvesting the tissues. On average, you can get about 8.7 oocytes from these patients, and then about half of them will mature, and then you can about have 75% fertilization rate. So you may end up with multiple oocytes and embryos, and in children, even in young children, we can get multiple oocytes. So you end up doing combined procedure at the same time. So in conclusions, we had significant progress in ovarian cryopreservation and transplantation. The precision and the pregnancy outcomes have significantly improved. This is a very important and now no longer experimental fertility preservation technique. ASRM recently removed it from an experimental category. I think we're not appreciating its full potential. It has significant advantages over an M2 oocyte freezing, specifically giving you the advantage of spontaneous ovarian function, reversing menopause, and not having to go through ART. And as I said, you can even combine it with that at the time of ovarian freezing. I think it's a true success for translational research. Finally, one area that's emerging is elective ovarian tissue freezing. Is this feasible to take tissue from their young people who are healthy and you want to postpone childbearing, or you want to use this tissue for hormonal restoration in the future? Now, our experience on ovarian transplant is all based on very young patients. I showed you that a lot of them are there in their teens and early 20s when you freeze this. And in general, the overall, about a third of that ovary results several years of ovarian function. And in general, we know that ovarian tissue cryopreservation is probably not very helpful over age 35 because there's less follicles there, and currently we're losing a lot of follicles after transplants. But once we improve the vascularization with the methods I showed you, this number may change. Therefore, we need to determine the risk-benefit ratio. So I'm removing ovarian tissue from a healthy woman. If I shorten her reproductive life by 4 years, when I transplant the tissue back, I should be able to give her at least 4 years. So the current formula may or may not be there. So we have to improve the survival, which we are. And once that improves, it may become feasible. But if you look at current studies that are based on how early the menopause is in women when their one ovary is removed, several studies suggest that it may be a couple of years, but they do not report when the ovaries were removed. The two studies that report the age that ovaries were removed, one of them is Rosendal's study. Based on that, if you remove the ovary at age 20, then the menopause happens at age 44, so about 7 years earlier. If you remove it at 30, it happens at 46. If you remove it at 45, it happens at 48. So the younger the patient, the more years that would be lost. If I remove an ovary from a 20-year-old, when I transplant it back, I should be able to get at least 7 years back to make it feasible. So that's the thing we need to determine. The second study is done on children who had their ovaries removed because of cancer diagnosis. And that shows a similar thing. On average, if you have your ovary removed as a child, you're experiencing menopause about 7 years earlier. So it looks like even in the very youngest patients, removal of an ovary may not cause more than 7 to 10 years loss, but in older patients less, and that's a whole ovary. So the question is, can we end up removing less, perhaps a third, and maybe be losing less, but may be able to give that back? So we don't have that answer yet. And I think if we're doing this, we have to do this under research protocols and see what amount of tissue would give us benefit. So in the end, I thank all of you for listening to me. And again, particularly Dr. Bedowski for arranging this, and your society, my other Brazilian fellow, Dr. Pacheco, Dr. Stobeski and Titus were my, from the Basic Science Lab, contributed to some of the basic work relating to transplant as well. And my other team members currently at Yale in research lab, as well as my collaborators at other institutions, as well as including Memorial Sloan Kettering. Juliana, we still count you in our institution. You come still operate with us. And other members of the institution and all past fellows. And if you need more information, you can go to our website. Again, thank you so much for the invitation.
Okay. Thank you very much for your excellent presentation, Dr. Oktay. I would begin making you a question about the status of experimental technique. I would like to ask you, what is required to remove once and for all the label of experimental for ovarian tissue cryopreservation? And does it have costs implications? I would like to know, in the USA, does health insurance cover ovarian tissue cryopreservation?
Thank you for your question. I think your question has two parts. First is, if I understand it correctly, what does it take for a procedure to be taken from experimental category? And second part is the cost, and is there an insurance coverage, correct? If these two are connected, first of all, there is no standard answer that what is required for experimental, for a procedure to be removed from experimental. In general, a couple of large trials that show effectiveness, people use that. For example, if you look at bone marrow transplants, that's what it took. But not every procedure that is amenable to that kind of procedure. So like ovarian cryopreservation transplantation, you can't randomize patients. You can't have hundreds of these in a study. So we had to wait for evidence to accumulate from small reports and etc. And by meta-analysis or large case series and everything, that had to be put together. And in the end, it showed that after 20 years of track record, it didn't have any major complications. It restored fertility at reasonable levels. And that convinced the practice committee at ASRM to change the category. So some of it is expert opinion. And also, I think your society's customs and ethical guidelines may play a role in that, depending on that. So I think it's not one size fits all. Insurance companies in the US do not cover experimental procedures. Up until now, it was never covered. And but we're hoping that ASRM will remove this from experimental category in December. And then we had the COVID crisis. So I don't think this was on their radar. We're hoping that slowly insurance companies will start considering this a covered procedure.
Okay, thank you. Giuliano, do you have some questions to make to the professor?
Yes. Professor, thank you so much for your great lecture. It's always a pleasure to have you here with us. And Professor, I would like to hear from you which candidates, which patients would be the best patient for you to think about ovarian tissue cryopreservation? Which one should you offer? Ovarian tissue cryopreservation? Which one should you think about oocyte cryopreservation? And also, Professor, in a second moment, do you have any kind of patient, any kind of disease, cancer, that you would contraindicate the ovarian tissue cryopreservation?
Thank you, Giuliano, for asking me all these tough questions. Well, you can tell that you trained a good fellow from their questions. So those are important questions. Number one, as I said, there is really no, procedure that one size fits situation. So as Juliana properly asked, you have to evaluate the patient. So up until now, because ovarian tissue freezing was still considered experimental, this was the approach. We would wait and see. If we have sufficient time, we would try to push the patient for ovarian embryo or oocyte freezing if they were sexually mature. And then if we didn't have time, or this was a child, then we would consider ovarian tissue freezing. However, once the ovarian tissue freezing removed from experimental category and covered by insurance, then that equation might change. But my tendency is still, even if I'm going to do ovarian tissue freezing, because for ovarian tissue freezing, you have to, 10 years later, you have to transplant, and then you got to wait for function to come back, have eggs collected, etc. So you have still an uncertainty. So if I can generate embryos, and if I can do PGTA, whatever, in certain instances, this patient has a little bit more assurance, even though it's a finite number. So ideal situation with me probably is to do egg or embryo freezing and then freeze some ovarian tissue in case that fails, I think, given the current state. Obviously, if it's a child, you don't have that option, but then when you do the ovarian tissue, you can aspirate oocytes, so you end up having eggs and embryos anyway. So I think you have to look at what's experimental, what's not experimental in your country as well. For Brazil, I think ovarian freezing is still experimental. And if you have concerns about the no coverage, I think you have to first see if you can do egg or embryo freezing. You can't do it, then go to ovarian freezing. So that would be the general approach. Now, in terms of safety of ovarian freezing in certain conditions, if the ovary is involved, grossly involved with tumor, that's going to be a challenging situation. Even if the ovary is removed and there's tumor and you freeze it, you would be hesitant about putting that in. But there is also research going on in vitro maturation. So there are patients who might in one day use their tissues which had tumor in it by having them cultured in the Petri dish and growing primordial follicles. It's very challenging. I mean, I've worked on that 20 years. That was also one of my earlier projects from England. So I don't know where that's going to go. There's that possibility. There's some cases like in between, like the granulosal tumors, like these Australian colleagues did, or it could be a borderline ovarian tumor. There may be a recurrence, but it would be local. For those patients, we prefer heterotopic transplant because it's easier to monitor and remove. Some people, say, oh, leukemia is a systemic disease and all that. Not necessarily. First of all, these patients with leukemia, they receive systemic treatment initially, non-gonotoxic, put them in remission. And we do this before bone marrow transplant because preconditioning treatment before transplant is the one that results in ovarian failure. At that time, they don't have circulating cells. Actually, xenograft studies have shown that. I showed you one of my most recent pregnancies is from a leukemia patient. But in every patient we set aside 1 vial of tissue for testing prior to transplant, not only for follicle density, which helps us decide how many pieces we will use for transplant. Also, if there are any tumor markers, as well as histology, we screen that piece. It's 1 piece, but that's another assurance. So case by case, but most cancers that you will see in young patients, lymphomas, they don't involve ovaries. Early stage breast cancer doesn't. Metastatic, it does go to ovaries. So stage 4 breast cancer would be one to watch. Obviously, in leukemia, they need to be in remission and before you do cryopreservation, which is the case in most cases. They're not going to come to you during the acute phase. Are there any? You're right.
We have a question from Rafaela Aguiar. And,
okay.
Rafaela is asking you, Professor, if the vitrification techniques they are advancing and they are close to be the best protocol to freeze ovaries, or maybe the best protocol will continue being slow freezing.
Yeah, so the question is, should we use slow freezing or vitrification? Nearly all live births are from slow freezing. That should be the primary method. If I'm going to use vitrification, I would use the Kitazato either open or closed device, because that is the one that has the best testing record. And however, I still wouldn't fully rely on that. So if you have to choose in between, slow freezing. But if you don't have option of doing slow freezing, you don't have a slow freezing machine, then the most probably at this point evidence-based and specifically designed for ovarian cryovitrification is the Kitazato kit. And I don't have any stocks in that company, so I'm not saying it for that, because it was tested in my lab. So I have some degree of confidence.
Okay. Dr. Oktay, what is the range of age in which ovarian tissue cryopreservation is feasible? You told us, and it's obvious that currently it's not a good option for women older than 35 years. But in children, we can perform ovarian tissue cryopreservation in very, very young children. Are there differences in harvesting ovarian tissue in pre-pubertal stage compared to peri-pubertal stage?
Yeah, thank you for the question. Yeah, so the upper age, once you go above 35, the density gets lower and lower. So that's not optimal. Yeah, in terms of lower age, there's no lower age limit. We've done ovarian harvesting from babies. As you know, females are born with 1 million primordial follicles and 500,000 left at puberty. So the younger the ovary, larger the ovarian reserve. And we also know that, you know, people have precocious puberty age 4 or whatever they will have. So the ovary is completely functional even during the 3rd trimester of pregnancy. So there shouldn't be any reason. And there are a couple of prepubertal transplants resulting in babies now. They were like maybe, 12, 13. And I have no doubt that 1, 2-year-olds will even have better outcome. With the prepubertal ovaries, they're going to be much smaller. And so they're easier to remove, but also easier to damage. So when you harvest the tissue, you shouldn't use electrical surgery around them. And when you harvest them, a pubertal ovary will be all primordial follicles. There's hardly any stroma there. So the preparation is going to be a little bit different. And even though you will have much smaller pieces, each piece will be loaded with follicles. So you will have less vials of tissue, but maybe even smaller pieces you can prepare. But each piece is going to be loaded with follicles. So there are some technical differences. But one thing to be careful that because it's going to be like a bean size or something, if you just burn near that ovary, you could destroy her whole ovarian reserve if you're doing it in children. That key thing is to protect the primordial follicle reserve because they're all sitting on the surface. And that bean is all packed with those follicles.
Okay, thank you. Giuliano, are there any other questions from our...
Yes. Professor, we have a question from Marcelo Cavalcante from the northeast of Brazil. And he asked about the dynamics of the follicle loss after ovarian transplantation. If the loss in the primordial follicles are higher, and what about the primary and secondary follicles? What happens? How the dynamics happens?
Yeah. So the question is there an accelerated loss? Now, some people have reported that they think there is more follicle activation. I have concerns about that data, and some people did that with chemotherapy as well. That as you know, our and others' research show that it's DNA damage induced, and so here is the thing. In general, in for example, rodent models, if you remove one ovary, the remaining ovary go through a temporary accelerated follicle loss, just a brief period of time. It's not quite clear why. It could be some inhibitory factors, and some people say AMH, etc. It is possible that there could be a temporary acceleration, but in reality, we don't see that. For example, if we had some boost of follicle growth, we should really see multiple follicles developing when the graft starts functioning. And so my concern is that what happens is that when they look at histological studies, they look at ratio of growing and non-growing. But that may have something to do with for example, primordial follicles may be dying at higher rate after the transplant, and the ratio may be temporarily changing. They're not necessarily due to hyperactivation. So I don't think that that is a clinically significant source of reduced longevity in these grafts. I think that's more related to hypoxia-related changes.
Wonderful. Professor, I have another question from Vinicius Lopes, and he's asking if during the ovarian tissue dissection, the medullary portion of the ovary can be of any use.
Well, here's the thing. The follicles produce stroma and medullary material. So you don't need to preserve medulla because it's basically fibroblasts and maybe some atretic follicles, etc. So as I told you, fetal ovaries are all primordial follicles, or the baby's ovaries, pediatric ovaries, because follicles have not started growing significantly, and the growing follicles produce extracellular matrix, and which make most of the stroma. So once you transplant, once follicles start growing, they're going to make stroma anyway. Unless you need stroma for your research or some other project, you don't really need to preserve any stroma. So, when you prepare ovarian tissue, you have to get them down to very thin, maybe 1 millimeter layer. Even then, you have stromal cells there. So it's not that you have zero stromal cells, and they will develop. Now, our transplant technique, we're using alloderm, which is a thick stroma. It has the similar components, so that may have an advantage to get it jump started, but you really don't need to save the stroma that you remove.
Okay. Another question, Giuliano?
Professor, I have a question.
Giuliano, I have a question for you. Are we charging per question, or is it how is that going?
Professor, I can pay in caipirinhas, Professor.
One caipirinha per question. That's too much. Okay, fire it.
So, Professor, I will take the opportunity, and I would like you to you just show us some data about planning using ovaries about for another reasons, and there are a little bit of discussion about hormone replacement, and you mentioned on your presentation that maybe the heterotopic transplant can be a good place for this situation. And also, when you presented your data, Professor, you showed us that the follicle dynamics are different, and you can get a mature oocyte in a very small follicle range, right? Do you believe that maybe because of a local hormone difference, or maybe because of there is a difference in pressure, maybe the transplant can survive longer there?
So your question is, would heterotopic transplant survive longer because the dynamics are different?
Yes.
You know, I don't know, but even though follicles are not growing to usual sizes, they're still going through same number of. You can see that here. Can you guys see my slides?
Yes.
You can see that they're still stimulating similar days to a normal cycle. So it's just a matter of physical maybe limitation or hormonal milieu. But in terms of longevity, the data we just prepared with Loris, if you look here, and in terms of longevity.
Professor, sorry, I think that the screen is not sharing with another participants.
They're not? It's not?
No, not now, not now.
It's not sharing now?
No, not now, Professor.
Okay, I don't know why. Stop sharing. Okay. Weird. Okay, let me see if I can do this again.
They will, Professor. They will start sharing your screen here on the presentation. So if you want to share your screen, they will start doing it now.
So can you see it now? Can they see it now? Or you mean the participants cannot see it? Is that right?
Yes.
Okay, well, only you guys can see it. I see.
Yes.
So in terms of longevity,
it's okay, Professor. They said that it's showing. Okay. You can.
Yeah.
You can
so
continue.
If you look at our data, so far we don't see a difference in longevity. But that question has a merit. With if it's only for hormonal transplant, we can come back and put one piece at a time, because when we put like 5, 6, 20 pieces so that patient has a long function, we can collect eggs. That's a different strategy. But we can come back and put one piece at a time, because I can do this under local anesthesia, especially subcutaneously. Potentially, if you do that, once one start, losing function, then you can come back, put another one. There is the possibility of then extending the longevity if it's only for hormones. Again, that needs to be tested, but theoretically, that could potentially be one strategy.
Wonderful, Professor. We have a few more questions here. Mark Caipirinhas.
I'm getting drunk here.
Yeah. Professor Paula Navarro, you remember her? She's my commentor here in Brazil. She's asking
of course.
if you are using any protocols, random start protocols, using progesterone to block the LH peak.
Yeah, that's interesting. Actually, I used that with this heterotopic transplant patient that I showed you. One of the things that what happens is, especially with heterotopic transplants, I noticed, and some other transplants, LH levels may run high, diminished ovarian reserve model. And one of the things I did to bring their LH levels down is to use progesterone together with sometimes antagonists. Of course, if you don't want to spend money, what I found is that progesterone alone is probably not sufficient. You would still may need to kick in some antagonists to do that, but it may help a little bit. But this is what I did with this patient, and now we just cryopreserve the blastocyst by doing that. This one here. But I don't think you achieve complete suppression that way.
Wonderful, Professor. Another question from Dr. Artur Dziki. He's asking about how much it costs for a Brazilian to freeze their ovaries, I believe in US, Professor.
For a Brazilian, we have special prices. I don't know. So the cost issues, like, it will vary from. The problem is that if somebody comes from overseas, they don't have hospital coverage. The hospital costs can be high, but I can see that it could be as high as 20,000 or something. So it would be like an IVF cycle you do in New York City. Cost like $25,000. So I know these numbers are huge for most parts of the world, but this is U.S. and New York. At the same time, if you get your ovarian tissue frozen, and you might get years worth of cycles out of that.
Wonderful.
Okay, another question, Giuliano? No.
Not now. Do you have any questions, Dr. Mario?
Oh, I would like to ask Dr. Oktay if there is a role, or maybe in the future, for the cryopreservation of whole ovaries with posterior vascular anastomosis of the ovarian pedicle. What do you think about cryopreservation of the whole ovary?
Yeah, the ovarian cryopreservation of the whole ovary has been actually studied in first mice and sheep models. In mice, really, it's not a vascular anastomosis. They take the whole ovary and stick it into the ovarian fossa. Mouse ovary is tiny, so you can freeze the whole ovary. It's not fibrous. You can do that. But sheep is more fibrous, but it's also much smaller than human ovary. Even in sheep model, majority of them had vascular failure, and the whole ovary was lost. So the main problem is that the optimal cryopreservation protocol for a germ cell versus vasculature, it may not be the same. It's not going to be the same. So to get a protocol that's going to penetrate into whole ovary and also will preserve vasculature, it's a very hard thing to do. Even with sheep, much smaller ovaries, that was a problem. The second thing is the design methods to be able to fit a whole ovary and freeze it. Slow freezing, that would be not technically possible. There's a company in Israel working on gradient freezing, where the ovary moves through these chambers to freeze whole ovary. But in general, technically a very challenging thing. And when you do that, if vascular accident happens, you're losing a whole ovary. At least with cortical pieces, I'm taking 1/3 of pieces, I transplant it, something happens, patient gets infection or something doesn't work, I still have more tissue. I put the whole ovary there, it failed, you lost the whole thing. So currently I don't see much future or advantages at the present time.
Okay, Giuliano, we don't have so many caipirinhas, and I think that maybe it's time to finish our meeting.
Yes. Professor, thank you so much for being with us and for your wonderful presentation, Professor. It's always wonderful to see your work, and and thank you for being so friendly with your friends here from Brazil.
It's not hard to be friendly with Brazilians. You guys are great people. So thank you again for having me, and looking forward to a day that we could travel there.
Okay, thank you very much, Dr. Oktay. I think we can finish our meeting. Good night for everybody.
Let me go get some caipirinhas then. Bye.
Goodbye.
Bye-bye.
Good night.